Welcome, everybody. My name is Katie Abbott, and I am an assistant professor of gerontology at Miami University. I'm also a Scripps Research Fellow, and we are excited to be doing some work around the PELI and want to support all of you who are out there doing this hard work. I have two exciting presenters that are joining me today. Sarah Humes is a certified therapeutic recreation specialist and has been working as a CTRS for 15 years, with most of her time dedicated to the geriatric population and in managerial roles. Sarah received both her bachelor's and master's of science in therapeutic recreation from Temple University. Her interests lie in the utilization of recreational therapy to increase quality of life for older adults and improving the overall quality of services that therapeutic recreation departments can provide. Sarah serves as a consultant on the Pelican Initiative and conducts research in preference-based care for older adults, and as an adjunct instructor for the Therapeutic Recreation Program at Temple University in Philadelphia. Our second presenter is Dr. Kimberly Van Heitzma. She is an associate professor of nursing at Penn State University, as well as the director of the Program for Person-Centered Living Systems of Care, and a senior research scientist at the Polisher Research Institute at the Abramson Center for Jewish Life, which is in North Wales, Pennsylvania, just north of Philly a little bit. Dr. Van Heitzma research focuses on seeking to understand the impact of contextual issues such as the physical environment, culture of care, staff interactions, interdisciplinary team processes, and psychotherapeutic approaches on quality of life and quality of care delivery for frail seniors receiving services in long-term care settings. So I'm delighted to have both Sarah Humes and Dr. Van Heitzma join us today. So our objectives for this webinar is, first, we want to be able to share with you the importance of assessing preferences in short-stay settings. And we recognize that this is a challenge, especially if someone is there for 3, 5, 10, 20 days. We also hope that you'll understand how preference assessment can be conducted in a variety of ways to meet the needs of your short-stay clients, and we're going to share some ways with you today. We hope that you'll understand how to adapt services provided to the preferences for short-stay clients, and we hope that you'll see how preference-focused care planning can help to maximize recovery and well-being of your client. All right, and then we need to give a little disclaimer about sort of what we're doing is that we do these quarterly webinars to disseminate findings from our research and collaborations with other stakeholders that we've had ongoing for over 20 years. We archive all of our webinars on our website that can be found at Preference-Based Living, and so we have several of these that are still there. We will archive this one as well. The overview of our advice. The recommendations we're presenting are based upon our experience and expertise, as I mentioned, of over 15 years of development, testing, and implementation of the PELI in various organizations. We hope to assist you in practicing preference-based, person-centered assessment in the short-stay settings with 3 options. First, utilizing a subset of PELI items, enhancing a current preference assessment tool with PELI items that you might already be using, and show you an interest tracking tool. So as a quick overview, this is going to be nothing new to all of you on the call. In short-stay settings, time is compressed, treatment schedules are busy. This is a fast-paced environment, and honoring preferences is to maximize recovery and well-being is really critical. And we hope to present strategies of ways to conduct timely, efficient preference interviews that promote a person's functioning and satisfaction with care. So there's lots of benefits of honoring individual preferences in short-stay settings. So let's talk about the advantages for individuals. When we see services aligned with preferences, people are more likely to achieve their highest possible level of physical, mental, and psychosocial well-being. And in these fast-paced rehab settings, most people concentrate on recovery and see their preference as secondary. Yet when offered the chance to reflect on their likes and dislikes, They welcome the conversation and appreciate that their preferences are respected. So when care team members take the time to ask about and respect preferences, individuals feel more comfortable, trusting, and positive about their relationships with caregivers. They may be more likely to become engaged in managing their chronic conditions. And meeting preferences can increase motivation to work hard in therapy. And this, in turn, may lead to shorter lengths of stay, improved adherence to care plans after discharge to home or another care setting, and reduced likelihood of rehospitalization. And so these are things that, again, all stem from understanding and meeting someone's preference. We also see advantages for provider communities. Customer satisfaction and reputation for quality are important things, and so clients are likely to be more satisfied and have fewer complaints when preferences are respected. Also, they may be more apt to express any concerns with care early on before problems spiral into major dissatisfaction. All of you know that federal regulations require preference assessment and evidence that preferences are respected. So this is one way that you can be meeting these regulatory mandates. Team members find that their work is more rewarding when individuals and families are satisfied with care. And you may gain new customers through positive reviews and word of mouth. And so at this point, we're going to change gears and we're going to start talking about our tip sheet to give practical advice. And again, if you haven't downloaded this, you can download it off of our website. We have the link in the chat box. And so at this point, I would like to turn it over to Sarah Humes, who will start walking us through some of the things that she has done. And hopefully, Sarah, I'm at the right stopping point here for you.
Yep, I think that's perfect. Thanks, Katie.
You're welcome.
Hello, everyone. So talking about when to do this preference interview, I think can be pretty overwhelming. The lengths of stay, as Katie said, can be brief and vary extremely based on the specific client needs. So it is important that the treatment team is strategic in finding the opportunities to explore preferences. Some advice is to consult the care team and find open space in the individual's schedule to be able to conduct the interview. And preference assessments when the individuals are most likely to be refreshed physically and cognitively would likely help you get a more successful interview and more successful information. So that might be prior to a rigorous therapy schedule starting. Also considering if family is visiting that client frequently. This may or may not be an ideal time for the interview. Maybe if you think you will need some proxy assistance from the family to obtain preference interview information, then it's a good idea to interview with the family there. If the family could potentially hinder that information, then you would obviously need to interview when the family is not there. And also consulting with the care team to ensure your interview will not be interrupted by additional nursing assessments or any other medical appointments or treatments that your clients may need. So ideally, we would like this assessment completed within 72 hours of an individual's arrival, which is a quick turnaround, but it gives us information about the person fast. And at the start of every interview, it is very important to explain the purpose of this interview. Individuals coming into short-term rehab are there with a goal in their mind, and then they're going to meet very many people in their first couple hours of time who are assessing their needs and asking what's going on with them and what their goals are. So explaining the purpose of why you are there will help get the interview off to the right start. And basically, a preference interview is there to learn about each person's preferences in order to make their time in the program as comfortable and successful as possible, as well as supporting their long-term health and their well-being after discharge. So as Katie mentioned before, we do have several resources on the Preference-Based Living website. And so don't be shy to kind of look through there and seek out those tools. We specifically have one about introducing the PELI with short-stay residents. So that can kind of help you to walk through that conversation with them. Okay, so probably at this point you are even more overwhelmed thinking, how do I complete 72 questions in 72 hours? How is this even going to be possible? So given the time and scheduling pressures that are facing individuals and staff during short-term stays, you definitely need a carefully planned process. And that's what we're trying to talk with you about today, is that there are options. If your time and resources do not permit using the full PELI, programs can still create a hybrid process that blends questions from the MDS 3.0, which everyone is already using, Section F, with items from the PELI or other related tools. Taking this kind of blended approach can provide a richer picture of the person's preferences than just the MDS 3.0 Section F alone, but still have a concise assessment. And you as providers can tailor your strategies to meet those organizational goals. So I'm sure there are even more options, but we tried to narrow down to 3. Option 1 being use a subset of items from the full PELI. Option 2, enhance your current preference assessment tool with items from the full PELI. And option 3, use the MDS 3.0 Section F items plus some type of interest tracker. So we're going to go into those 3 options now. So option 1, using a subset of items from the full PELI, would be asking the PELI questions that appear on MDS 3.0 Section F. So for those of you who may not know, the items in the MDS 3.0 Section F are almost identically mirrored in the PELI, with additional kind of ways to get into more detail. The PELI provides some additional questions to get more detail out of those answers. And so you would take the 72-item PELI and convene a group of staff, including as many variety of people as you can: administrators, activity directors, physical and occupational therapists, nurses, direct care workers, even individuals and family members, and choose some core questions from those 72 PELI items. You may decide at your organizational level to ask the MDS 3.0 questions and an additional 5 questions, maybe an additional 10, maybe 20. You would figure out what meets your organization's needs the best. And again, we have a resource on the website that can assist you in this process, which involves how to select and prioritize preferences items to best meet yours and your clients' needs. So there's another tool from the site there. Okay, so option number 2, potentially your organization already has some type of interest assessment that it's using, maybe some kind of leisure interest checklist. Do you read? Yes or no? Do you garden? Yes or no? And so looking at using the MDS 3.0 and then taking your tool that you already use and seeing if there's ways that you can enhance that information. That may be as simple as adding the ranking ratings that are in the PELI, so answering that something is very important, somewhat important, not very important, not important at all. That could help you draw more specific information, and that also looks more like how the MDS is worded. Adding a few well-chosen questions could really reveal some important information about your individual's wishes. So, for example, you may find out that a client has a preference of dogs, and that's great. You figured out that interest, but then digging deeper and finding out that their preference is really to be able to walk their dog around the neighborhood, that now gives you details and possibly even a rehab goal or a way to work through their therapy sessions in a stronger fashion. Okay, so our third option is to just use the MDS 3.0. You're already doing it. You already have to do it. It gives you some information on leisure preferences and personal care preferences. And then take that data and basically add in something we're calling an interest tracker, or a simple checklist that captures more information about the activities that each person in your program is enjoying. So we have an example here on the next slide. You'll see on the left-hand side, it's basically listing, excuse me, I apologize for that. It's basically listing all the different types of leisure interests, and then across the top you have each individual within that hallway or unit, or however you want to divide that up. And basically the purple areas are telling you which interests people have. So looking at this chart here, you can see that the two clients, the very first purple area of books, Mr. Jones and Mrs. Brown, both have an interest in books, which could lead you to an opportunity for a book club or some kind of book exchange between the two of them. The next line down, you see that all 4 clients listed here enjoy music, but if you look at the comments section down at the bottom, all of their music interests vary. Therefore, taking them to some type of large music program that the rest of the facility may also be attending is probably not going to satisfy their individual preferences. And more likely in this case, providing individual opportunity to listen to music with a CD player or an iPod may be more of a suitable intervention. This tracker can then be kept somewhere in a binder in a community space for all different staff to have access to. That way you can increase the support given for pursuing independent leisure. So all staff would have access to see this and can help support all of the clients in that area in pursuing what kind of things they prefer. Additionally, if there happen to be anyone suffering from behavioral disturbances during their short stay, knowing their preferences can actually help with decreasing some of those. Okay, so as I said, it can provide some easy communication, at a glance details regarding the preferences, easy communication across disciplines, days of the week, staff shifts, things like that. Furthermore, if you do have certified recreation therapists at your organization, this could give them at-a-glance information to use for leisure education sessions and discharge planning interventions for how leisure can be continued at home and how it might need to be adapted. And one kind of fleeting thought I had at one point was that effective preference-based recreation therapy has been shown to support the prevention of and recovery from delirium in individuals post-hospitalization. And in my personal experience, it's been something that's kind of been few and far between, but occasionally there is a client that comes to short stay and is experiencing some severe delirium symptoms. And knowing their preferences and being able to provide treatment that is preference-focused can lead to a better success and get them out of that delirium state faster and into what is more their ideal ability to participate in their therapy sessions. Okay. So as an organization overall, it's also important to include self-initiated activities. I think at times it can be easy to forget that many of your clients might be able to pursue something independently if they are given the right resources. And that kind of can relieve the staff and relieve the organization as a whole from feeling like they have to provide so much. Something simple like an activity card or cabinets where resources can be easily obtained, and then the use of those resources can be tracked by staff so that you're able to show that you are meeting preferences and meeting needs. Making health education literature available is something that can easily promote recovery and management of chronic conditions. It's rare that somebody's coming into a short stay with just one simple diagnosis. There are usually many comorbidities going along with what they need, And so using health education literature can be a good way to help that. Okay, so for me, it's also extremely important to note that every organization is asking the same question. How important is it to you to do your favorite activities? This is a required question from the MDS 3.0, and basically it is probably one of the most wide open questions you could ask. How important is it to you to do your favorite activities? Very important. What do you find out from that? Pretty much nothing. You need to go further, for sure. Can you tell me what your favorite activities are? So if you are going to go the route of only using the MDS 3.0, you really need to add to this one specific question. So if you're not going to go through the PELI and use those 72 items, you just have realized that you don't have the resources in your department to handle that, that's fine. But using this question to dig a little deeper will help you meet those person-centered care goals so much easier. So adding on to that, can you tell me what those favorite activities are? And then even using your interest tracker, whatever you've decided to put on there, go straight down the line of the interest tracker. Do you have an interest in books, in music, in gardening, and kind of go through all of these things. Additionally, you could even go as far as asking the same ratings as the PELI. So is gardening very important to you, somewhat important to you, not very important, not important at all? Really kind of digging deeper into that question. Otherwise, it's just kind of giving you very minor information and you're not going to be able to do much with it. Okay, so on that note, it is also extremely important to encourage the interviewers to follow up every single time an individual chooses the response, I can't do. I think that it can be overwhelming for an interviewer to sit with somebody who just is saying they feel that they can't do something. Reading was very important to me, but there's no way I can do it anymore. It can get uncomfortable for the interviewer. Sometimes clients can even get very upset at the feeling that they've lost the ability to pursue a preference. But really what this allows you to do is probe for details so that you as a team can get a better sense of that person's interests and ways to adapt the activities. If they have a preference that they've lost, being able to adapt how that preference is fulfilled for them could be huge in their overall recovery. So a really simple example, you find out that an individual has an interest in gardening. Through probing for details, you find out they only like gardening for flowers. They don't want to garden with vegetables or anything else. But they also feel like they can't get down on the ground to garden anymore. And so they've kind of written that preference off. Well, now you have worked through everything with them, and you can move to potted plants in their room as a successful adaptation. They can still garden with flowers, they can still care for something, but the amount of detail that they need to be physically involved in is not as much. Okay, so some additional thoughts. We recommend asking individuals about a wide range of preferences. So when you decide to go to that, option 1 or 2 especially, and then in option 3, if you are asking those details about the favorite activity, really making sure that you have a wide range of preferences, asking as many open-ended questions as possible so that you're encouraging a genuine dialogue about what is most important to each person during their short stay. Simple little questions like, what is most important to you while you're cared for here? What is most important to you when you return to your previous living arrangements? So the first question alone, maybe someone says, well, I'm here for rehab, so it's most important to me while I'm here to be able to walk again. But then you find out that it's most important for them when they return home to be able to walk all the way through their neighborhood with their dog. And those are two very different answers, so it kind of gets you more information. You never know what kind of answers an individual is going to provide. They might end up revealing brand new likes or dislikes that are significant to the way that you can plan the daily care and activities at your organization as a whole. I want to tell a short little personal story here that I think connects. Hopefully you'll see a little bit of a connection. My grandmother was 86 years old at the time and went into the hospital for an elective surgery. She did not come out of the surgery in full recovery, so she ended up spending 3 weeks in the ICU, which then led to a short-term rehab stay in a long-term care facility. It was really difficult for my whole family to understand what short stay in long-term care was like compared to a short-term rehab in a 3-hour-a-day skilled rehab facility. And I think also for the organization as a whole, this particular facility was one that was laid out where a client that's there for short stay, so somebody there for 15 days, maybe roommates with or right next door to somebody that was going to be there long term. So the staff didn't necessarily have maybe a full grasp on how to treat each client differently based on their discharge needs. And basically on paper, she was an 86-year-old woman who had just spent 3+ weeks in the hospital. No one was really aware that her personal goals were to get back to living completely independently, cooking 3 meals a day for herself, pursuing her leisure fully independently. I mean, she had gone from full independence to an elective surgery that just didn't go the greatest. And so if this organization did not have in place the ability to ask more detailed preference questions, they may not have learned that from her. And the direct care workers may not have learned that from her if it wasn't a culture of the organization to make sure that those preferences were important to find out. So I hope that kind of connects to something for you all. So I think a worry for providers is whether or not you should ask questions only about the activities that you currently offer, or whether you should really explore preferences outside of your usual menu of options. What if I ask preferences and they want me to bring, a live circus in every week? Something that seems so outrageous that you can't do. But keep in mind that if you do focus only on the current activities that you offer, the things that are easiest for you to offer, you really are offering more of a facility-centered care versus a person-centered care. And the new survey processes are definitely looking for more person-centered focus and wanting to see evidence both on paper and when they approach the individual clients and the individual employees. So whenever possible, it is best to listen to an individual's full range of wishes. And again, typically people aren't asking for the moon. They're happy to know that you even want to hear anything about what it is that they may prefer.
And so one of the questions that came in is, you just said that federal regulations require preference evals. Is the PELI itself required? And so that's a good clarification. I misspoke. The federal regulations speak to providing person-centered care. One major component of being able to provide person-centered care is understanding, first of all, what someone's preference is about their care. And so the PELI itself is not required on a federal level. It is required in the state of Ohio as part of a pay-for-performance initiative, and it's being used in Tennessee as part of a value-based initiative. But I want to clarify that it's not a federal regulation to use the PELI. Hopefully that clarifies that good question. All right, and then the next question, Sarah, this is probably for you. Could you please clarify the within 72-hour rule? We use a baseline care plan which asks what their favorite activities are, what comforts them, and what causes them stresses. Are you saying that the baseline care plan does not meet the requirement that we should be completing the PELI interview within those 72 hours? We complete the PELI within the first 5 days after the resident's admission and then add the information to the baseline care plan.
So that sounds wonderful. That I like those questions in that baseline care plan, and I think that's great. Some organizations are doing nothing until that 5-day mark, and the 5-day MDS does not include Section F, so then that's kind of leading some organizations to still not dig deeper into preferences until later when that full MDS is required. So that is kind of more where that 72 hours came from. I think if your organization has a system in place that assesses some preferences and gives you some detail about the individual beyond just their medical diagnosis and medical needs, then you're fully within where you should be. Just as long as there's some kind of tool to get that, make sure that people are sharing that information off of the care plan. Sometimes care plan information can get lost and not trickle down to direct care workers. But it sounds like that's a very thorough process already.
And so what we want to go to next, we have another question here. Since the PELI is required in the state of Ohio, do we have to use the full PELI with every resident, or can we use the adapted measures discussed here with the MDS 3.0 Section F plus the additional questions? And so that's a great question. Thank you, Caitlin. There are different things that you can do. The tip sheet on how to get started that we have on the website that we can send to you if it's difficult to find has that is exactly one of the options, that you can use the MDS Section F plus those nested items in the PELI. So just like Sarah was saying, if you're asking about, the favorite activity, well, it's not enough to just know if it's very important. You need to know, well, what are their favorite activities? And so, yes, you can do the Section F with the additional questions in that way. Sarah, do you want to add any more to that?
Just that's actually where this tip sheet and webinar ended up coming from was I felt that likely with the PELI kind of rolling out in the state of Ohio and most organizations then starting to take it on, would feel overwhelmed with how to meet the needs of using a 72-item assessment in short stay. And so kind of creating some type of tool that essentially gives permission to figure out flexible ways to do that. So that you are still being as person-centered as you possibly can, but at the same time realistic within the short stay setting.
Nice. Okay. And then another question that has come in, has there been any research done discussing how the PELI is a palliative tool or with overlap between the PELI in practice and palliative practices? So I don't know, Sarah, if you have any thoughts. We have not done any official work in palliative care, but we very much feel that it can provide a lot of comfort for somebody to know you and to see you and to recognize you as a person and to get to know you. We think that that's crucial to well-being. Anything else that you'd like to add, Sarah?
Echoing what you said, I think overall, especially me as a recreation therapist, I really believe that if you know someone's preferences and you can use those preferences to help restore and rehabilitate or even just maintain current functioning to the best extent possible and provide that support, then you're going to have so much more success. Whereas if you're just trying to, utilize an intervention because it's been proven versus the intervention that has been proven and is also an individual's preference. So more of my own core beliefs than actual research I've done, but I think it absolutely doesn't hurt.
Great. And then we've got another question here. What's the difference between a preference and a goal? So we've talked a lot about both, you know, a goal for the rehabilitation stay, but also, you know, can you just talk a little bit about what's the difference there between a preference and a goal?
So again, in short stay, I mean, obviously we're working towards functional goals and functional improvement to get somebody back to their baseline or get somebody to the best, highest level of independence that they can be. But again, if you can specifically meet those needs based on preferences, I believe that you'll get more motivation out of the individual, more adherence to their actual therapy goals, more desire to want to participate, and even taking it further into them being able to continue their preference at home as they did in a rehab setting with their, you know, their therapeutic goals. Now they're at home and they can continue that preference and meet those needs and hopefully stay home longer and have a less chance of returning. I think preferences can actually give context for goals. So again, if the therapist says that, you know, this person needs to be standing, have a standing tolerance of X amount of time and walk a certain amount of feet, and that person's preference has to do with animals, why not be able to incorporate those animals into that therapy session, or at least discuss it within the preferences? You know, working on this standing, working on this walking is going to get you home to walking your dog. It's going to get you back to that preference that you enjoy. And in the meantime, being able to meet those preferences on a small scale while they are staying with you in the facility.
What we've talked about, too, is that the preference allows for a discussion that can frame the goals. So it can give some context for the goals. I want to increase mobility for the preference I have, right? So specifically, how do you direct functional improvement so that you consider all aspects of the person? And lots of people don't think to share preferences because they don't think it's important. It hasn't occurred to them. They might not have ever been in this situation before. They might not have ever had to explain to somebody that they have a preference for bathing in this way, or they have a preference for meeting a recreational preference in this particular way. And so, again, asking people to think about that, you may have to give them a little time to respond as well. And finding pleasure in your preferences and using that pleasure to motivate the healing process, right? It's that kind of notion of putting your oxygen mask on first. And as you mentioned, Sarah, they might fear that they are not able to do a preferred activity. But as you've said, there are lots of ways to modify activities that can allow them to engage in things that are deeply meaningful for them. All right, and so you mentioned, Sarah, that the direct care worker might not have access to that care plan. And we do know from our research that there are barriers to direct care workers finding out preference information that might be assessed by a different individual because they might not have access to electronic health records, and that's not the best way to sort of share information with them. And so, you know, why should the direct care worker be informed about preferences and rehab goals?
So, you know, I think especially in the short stay client, the pace is very different than the long-term cycle. You know, so for assessment in long-term care, it's on a quarterly basis unless there are significant changes that occur. I think that it's more likely that the direct care workers get to learn the pace of what's going on with that client and what kind of needs are being met for them. But the direct care worker may not know the rehab goals. Those goals could change every day, every other day. and there just might not be enough time for them to be able to get that information. So having, the interest tracker is something that could be used, could even have some goals written on it, or some deeper information related to goals, but being able to have that interest tracker in something like a binder that's not part of, it could still be part of the medical record, but something that's copied into a binder or something like that for the direct care workers to have access to, and just understand where that person needs to be from when they first start working with them until the end. And then also, most recently I had the pleasure of working at an organization that had a separate short stay unit or short stay wing. So, all of the residents that lived there were there for short stay. So the staff could be scheduled to work just in short stay, and they may be able to work with a different mindset. I think the majority of organizations have short stay embedded within their long-term residents, and so that's another reason that having some type of communication system where direct care workers understand what's happening differently with a short stay client can lead to more success for that client's time there overall.
Awesome. And then one more thing that I'd like you to respond to, and then again, if other people have questions, please get them up there on the Q&A. Is you mentioned preference-focused treatment for delirium. Can you say a little bit more about that?
So, people in a state of delirium after a hospitalization or a newly acquired injury, it can be a very complicated scenario, especially because you're likely not seeing that person perform cognitively or physically at their actual baseline. And so they could end up being kind of placed into an area where they are labeled with, dementia or behavioral disturbances or things that hinder their ability to get their therapy the way that would really help them. And I think it's also something that's not too common to see in short stay. It's probably usually resolved at the hospital before they're transferred. And so when someone is experiencing delirium, more consistent information, even reality orientation, which is not common with somebody that is experiencing dementia, all are very important ways to kind of help them get out of that delirium. And so knowing their preferences and being able to just really streamline the services you provide for them based on things that they previously had an interest in, that's going to grab their attention and be able to focus those services you're providing is going to help them.
Awesome. As you all know, we seek to create opportunities for providers to interact and learn from one another by sharing successes and stumbles. We'd love to hear from you. We'd love to, we'd be honored to visit your organization. We're interested in understanding, how you've implemented the PELI and what barriers and facilitators you have encountered. As I've mentioned, you can find out more resources on our preference-based-living.com website. We'll post that link in the chat box as well. Again, call us. Call our helpline. Right now we have funding through the Ohio Department of Medicaid, and for the next year we've got this funding. We are out here wanting to help and eager to help. And so at this point we've got one more question that I've seen come in, and I'll put my email and also Kimberly's email. I'm sorry that Kimberly wasn't able to be heard on our webinar. Apologize for that. Her advice is always so crucial. But one question that came through, do you still get the same payment rate from the Ohio Department of Medicaid if you only use part of the PELI questions? Our understanding, again, we're not the regulatory bodies here by any means, but our understanding of how the payment reimbursement works is that it's a self-reported checkbox, and however your organization is, the policy around your organization fulfilling the PELI is how you deem that, whether you're checking that box or not. And so one thing that we want to highlight is that you can achieve that mandate in many different ways. Again, go to our very first webinar. We did have officials from the Ohio Department of Medicaid join us and talk about that, so you can see that as well as something that can give you some feedback. But essentially, there are lots of different ways to meet that mandate, and however your organization has put its PELI policy together is part of that. But I think part of it could be if you're just using the MDS items with those nested questions from the PELI, that can be part of one way of your policy, yes. And so at this point, Sarah, any other last comments that you'd like to make?
I was just going to piggyback on that. We should have added a slide about policy. So, you know, it's always a good idea, whatever you do decide to implement, to write that into a policy. That just covers you to make sure that you're fulfilling what you said you would fulfill, and it's an easy way or easier way to answer surveyors' questions that might be out there, and when you can show that you actually have a plan behind what you're doing and why you're doing it.
Nice. And then we've got one last question. What if someone stays with you for more than 20 days? So what if maybe somebody came in as a short stay, but now they've converted maybe to a long stay?
Yeah, so I think at that point you would want to go back and ask more questions, or make sure that the preferences that they've identified are still the same, or how they might change now that they may be staying with you indefinitely or a little longer, to kind of make sure those preferences are spread throughout the agency.
Fantastic. So at this point, I want to thank everybody for joining us on the webinar. The tip sheet is already available on the website, which has all this information. It just doesn't have the great sort of description and explanation that Sarah can provide. So I want to thank our presenters, Sarah Humes for joining us today, and Kimberly, who joined us as in spirit, but couldn't be present on the webinar. So again, I want to thank everybody. We'll leave this up for another minute or two so that you can get signed out. And of course, if you have any questions, don't hesitate to contact us. And we appreciate your attention and for joining us today. Thanks, everybody.